Welcome to a brief presentation on attribution theory and strategies for enhancing our engagement with patients, clients, and team members, and avoiding making inaccurate assumptions about the behavior of others. My name is Diane Elsie, and I'm an associate professor at the UB School of Social Work, where I direct the MSW program. There is much that can be said about attribution theory. I am only going to touch on a few ideas. I encourage you to take a look at the references at the end of this presentation. First, it is important to understand something about our perceptions. Our perceptions influence how we communicate with others. Our perceptions are typically selective and involve bias. Our own culture, our group memberships, and our social identities are major sources of bias in our perceptions. Our perceptions also involve categorizations. We often unconsciously put people into categories. This placement of people into categories can inhibit effective communication. The more rigid our categories, the less we are able to see individual characteristics of the people with whom we are communicating, and we will be less effective in our communication. Attribution theory is concerned with how we attach meanings to the behaviors that we perceive in others, how we interpret the behavior of others, how we make sense of what we see and hear. When we attach meaning to the behavior of others, we are making attributions. Social attributions are concerned with how members of one social group explain the behavior of their own members and members of other social groups. Attributions are based on our knowledge of cultural expectations. We often make errors in attributions or misattributions when we are looking at the behavior of people outside of our social group, when we are communicating with people we do not know, and especially when we are communicating with people from cultures that are different than our own. When we communicate with people from a different culture, we are more likely to attribute the cause of their behavior to one particular characteristic, often to their cultural background or group membership, particularly when we are explaining behaviors that we perceive to be negative. However, when a person from a different culture is behaving positively, in our view, we are more likely to attribute that to situational factors. We usually do the opposite with ourselves. We attribute our positive behaviors to our personal characteristics and our negative behaviors to situational factors. Unfortunately, when we are looking at the behavior of others, we also have a tendency to stop looking for alternative explanations for behavior when we have found what we think is a reasonable explanation. This gets in the way of effective engagement and communication with our patients, clients, and team members. So, how do we stay open to different perspectives and alternative explanations? How do we maintain a stance of curiosity about what someone's behavior may really mean? To recognize the perspective of others, we must understand the three cognitive processes involved in our perception of behavior: description, interpretation, and evaluation. Description is an actual report of what we have observed with no attributions attached to our observations. No social significance is attributed to the behavior. Interpretation is what we think about what we have observed. It is important to keep in mind that many interpretations can be made for any given description of behavior. Evaluations are positive or negative judgments concerning the interpretation of the behavior. We often jump right to interpreting and evaluating people's behavior, and we skip the descriptive process. This leads to misattributions and ineffective communication. Remember that our interpretations are usually based on our own cultural backgrounds and biases. If we stay at the descriptive level, we can explore with our patient, client, or team member their own explanation of their behavior, the meaning that their behavior has for them. We will be more open to alternative explanations. Let's look at some examples. We often hear statements such as, "Oh, he doesn't care about his health," or "Oh, he's irresponsible and unreliable," or "Oh, he doesn't respect the doctor's time," when a patient may miss appointments and not call the office to say he's not coming. What are some alternative explanations for why Mr. Jackson may have missed his last 2 appointments with his physician and did not call to say he was not coming? He may lack reliable transportation and perhaps lost his phone. He may be caring for a family member who is in a crisis. He may be forgetful. He may be afraid. He may have felt disrespected by someone the last time he was in. We often hear people like Mrs. Edwards called non-compliant, and sometimes we hear statements made like, "She does not care about her health," or "She's asking for trouble." What are some alternative explanations for why Mrs. Edwards missed 4 doses of her medication in the last week? She may be trying to stretch her medication to save money. The medication may be making her feel worse. She may not understand the directions. Someone else at home may be using her medication. She may be forgetful, or perhaps she is feeling depressed. We may hear people call young women in a situation such as Ms. Franklin's promiscuous, and people may say she has low self-esteem and does not respect herself. What are some alternative explanations for why Ms. Franklin has come into the clinic with gonorrhea 3 times in the last 5 months? She may be in an abusive or coercive relationship. She may be embarrassed to use condoms. Her partner or partners may refuse to use condoms. She may lack accurate information about condoms and about STIs. She may feel conflicted about using birth control and methods to prevent STIs. She may lack self-esteem. Finally, what are some alternative explanations for why Sylvia and Mark are saying what they are saying about their patients? They may feel powerless. They may feel frustrated. They may feel like nothing they do makes a difference. They may lack skills to engage with their patients. They may lack an understanding of their patients' lives. Or they may have negative attitudes and feelings towards their patients and be too judgmental to be effective. What can we do to avoid making inaccurate attributions about the behaviors of patients, clients, and team members? What can we do to more fully engage with patients, clients, and team members around their experiences? We can stay at the descriptive level. We can express openness and curiosity about the experiences of others. We can listen with empathy and understanding to the patient's or team member's perception of the situation. We can invite the person to tell us more. We can use phrases such as, "Please tell me more about what it is like for you to take your medication. Please tell me what is hard for you in taking your medication. Please tell me what you know about condoms. What do you think would help you talk with your partner about using condoms? Sylvia, you sound really frustrated with your patient. Are you? Would you like to talk about it?" Please reflect on the following. You are seeing Rosa Alvarez, a 55-year-old woman who has several chronic illnesses, diabetes, high blood pressure, and asthma. She has been prescribed several medications, but in the last 2 months she has not been taking them as directed. Her blood pressure is quite high, and she has poor diabetes control. She has also missed the last 4 appointments that were scheduled with you. Keeping in mind attribution theory, describe Miss Alvarez's situation. What are possible explanations for Miss Alvarez's situation? What are some questions that you might explore with Miss Alvarez? And that brings us to the end of this brief PowerPoint presentation. Thank you so much for your attention. A reference list follows.